Nick Silver's Institute here at NYU Silver School of Social Work. And along with the Community Technical Assistance Center and the Managed Care Technical Assistance Center, I want to welcome you to today's webinar, Trauma-Informed Care, the Do's and Don'ts of Serving Survivors of Intimate Partner Violence. So before we get started, I just want to take a moment to kind of orient you to the WebEx system so you know how to participate in today's event. So please note you've been placed on mute to avoid any background noises, so it won't distract anyone from listening to our presenters today. If you come across any technical issues, please chat into the host, which you'll see the host name today is Brianna, so she'll be able to assist you. And you'll have the opportunity to submit questions for the Q&A portion of today's presentation by using the chat box feature, which is located on the right-hand side of your screen. So to ensure that we have enough time to answer everyone's question, we encourage you to put in your questions throughout the presentation today. We'll be collecting them and then addressing them during the Q&A portion. So we are very excited to have Kylie Rose and Ariel Weisenfeld, who are both licensed social workers from New York Presbyterian Hospital Domestic and Other Violence Emergencies Program, also known as the DOVE program. So Kylie Rose serves as a licensed social worker at New York Presbyterian Hospital, the DOVE program. Ms. Rose graduated with her master's degree from New York University, where she conducted an independent study on intimate partner violence and female substance use. Prior to being a trauma-focused psychotherapy and researcher, Ms. Rose worked as a coordinator of the legal program at a domestic violence shelter in Wisconsin. And by way of direct practice and studies, Ms. Rose has developed an eclectic approach to trauma treatment, which is client-centered, surrounded by mindfulness and survivor safety. So Ariel Weisenfeld is an LMSW and has a postgraduate certificate in trauma therapy from the Institute of Contemporary Psychotherapy, where she was trained in different trauma processing modalities, including eye movement desensitization and reprocessing, EMDR. Before working at New York Presbyterian's DOVE program, Ms. Weisenfeld worked as a social worker at JCCA Eden Wall Center, a residential treatment center for traumatized youth. And currently, Ms. Weisenfeld works as a therapist and Enough is Enough coordinator in the DOVE program, where she provides therapy to domestic violence and sexual assault survivors and works with New York City colleges conducting trainings, workshops, and clinical intervention around sexual violence. So once again, thank you for joining us, and I'm now going to pass it along to Kylie and Ariel to get us started.
Thank you so much. Can you see the screen with our presentation?
Yes, we can.
Okay, great. Okay, so we're all set? This is Kylie speaking right now. Thank you, everyone, for joining us. Today we're going to talk about the do's and don'ts of serving survivors of intimate partner violence, which we'll often refer to as IPV or domestic violence interchangeably. Just to get started, we would like to know in what capacity our listeners are working with survivors of IPV, just to get a sense of how deep into the material we need to go into the introduction and to kind of focus our presentation to what you may be focusing on with your patient. So if you could just put in the chat box in what capacity you're working with survivors, that would be really helpful. So as an overview of what we're going to be discussing today, first off, we just broke down trauma-informed care, and we're going to start off with the trauma piece of it and what it looks like in working with survivors of IPV. So, excuse me, to begin, we'll go through a brief introduction of what intimate partner violence looks like, defining IPV and also the word trauma with this population, and how they're often affected by post-traumatic stress disorder and different trauma responses that most likely all of you see if you're working with this population. Then we'll move on to being informed and what it means to be informed, defining it in regards to how you interact with your clients and you know, what your work looks like and in your interactions and with your personal reflections and cultural awareness, and also considering how informed you are on diagnosis that may be common that a lot of, you know, the patients or clients that you're working with come in with, but not necessarily are the right diagnosis. And lastly, is care and how it's implemented. So this is more so the doing piece of it. When is psychoeducation appropriate in regards to where the patient or client is at in the healing process, treatment responses for both you, the provider, and the patient, and what's happening outside of the session regarding self-reflection for the clinician, but also safety and progress in treatment for the survivor. So, Giselle, I don't know, do you have the ways that people are interacting with People Collected, or should I move forward?
So I think if you keep moving forward, then we'll keep collecting those. But right now, actually, just to mention that your slides aren't moving forward.
So what do you see now?
We still see your intro slide. Your comment form.
No, she doesn't see this at all. Okay, give us 1 second.
So right now you don't see defining IPV?
No.
Okay.
So give us all 1 second while we try to figure this out.
Go to what you did last time.
Sorry, everyone. This was working.
Okay.
How about now?
All right, we're at overview.
Perfect.
There we go.
So I basically just went over all of this and it wasn't moving?
Yes.
Okay.
Thanks,
so did you just see all the
patience.
animation happen?
Yes, we did.
Okay. All right. Great. Okay. So moving on to defining IPV. It's helpful to pick a definition just so we're kind of all on the same page of who we're working with. I like to use the definition from the Center of Disease and Control and Prevention because it includes stalking and psychological aggression, which often is overlooked. So the term intimate partner violence describes physical violence, sexual violence, stalking, and psychological aggression, including coercive acts by a current or former intimate partner. Also, it's important to note that it could also still be happening from a former intimate partner, even if the survivor has moved on to another relationship. I think that's really important to point out.
Mm-hmm. And just also to add, as we go throughout our presentation, we are, going to use certain words and certain terms. We're going to use survivor and victim interchangeably, and we do this in part because we like to really use that word that best describes that person. So we know that there's a big discussion around we're using survivor versus victim, but in this case, we're really just going to use both of them. And we're using the term IPV while there are still other terms like domestic violence and family violence. We think that IPV is the most encompassing term for us to use. So you'll hear us use that as well. And then for our examples, we are using he as the perpetrator. So we're using the male pronoun as the perpetrator, but we do want to point out that it's not only a male-dominated perpetrators are not all men, and that women can be perpetrators and that women can be victims, but for just the purpose of our presentation right now, we are using men as perpetrators and women as survivors, but we do want to recognize that it is interchangeable.
So Kylie and Ariel, before you move on, it's Giselle here. I wanted to share a few of the types of settings where people are working in. Okay. Because we have a lot of answers in now. So some people are in psychotherapy centers, care management, an immigration attorney, victim advocate, substance abuse, chemical dependency treatment, volunteer at a women's shelter, supervisors, addictions counselors, supportive housing, a children's clinic serving families who survived the trauma of IPV. And let's see, did I miss any? Kind of a lot of counselors providing therapy to patients, many of whom have trauma histories with DV. So that's just a sampling of some of the answers we've gotten.
Okay, great.
Okay.
So moving forward, obviously we have a diverse group of people that we're presenting to. So I'm going to keep the intro to IPV pretty brief, but I do think it's important to acknowledge, the basics, just because not everyone obviously is working at a different level with survivors. So usually the go-to instrument that we use in describing IPV is the power and control wheel. So if you see at the center of intimate partner violence is power and control, and everything else around it is basically types of tactics that abusers use in order to keep power and control over their survivor. So, intimidation, emotional abuse, isolation, blaming, minimizing, denial. I'm guessing a lot of you have seen these. Using children is a common one. Using gender roles with privilege, economic and academic abuse, and, as always, threats and coercion. And going with the power and control is the cycle of abuse. So for those of you that work directly in the field, you've probably seen this before, but, with the cycle of abuse, usually as providers, the place where the provider is going to end up hearing about the violence or having a client come in crisis is usually at the second phase, which is the incident, the verbal, emotional, and physical abuse, anger, blaming, arguing, threats, intimidation. And this cycle can, depending on the couple, can switch very rapidly or take months. So, right now I have a patient that literally week to week goes from 2 to 3. But as providers, it's, really important for us to recognize our internal reactions when 1 week someone's wanting help and then by next week they're at, step 3 where they've already reconciled and everything's good and everything's going to be okay. But just to keep our frustrations in check with that, because obviously they come from a caring place, but it's also recognizing that it's a part of the cycle. And explaining that to the patients when it happens and if they're at a place where they can take in that psychoeducation.
So we just have a few statistics here about IPV, and these are not the only statistics out there, although we did want to focus on the National Coalition Against DV, as we feel like they have the most accurate statistics and the ones that really show a wide range of numbers. So the first one is 1 in every 4 women experience DV at some point in their lives, and that's a pretty big number. If you can look at your caseload and really just see how that number shows in your caseload, it's really prevalent, and it's a really big issue that we're tackling right now. Every year, 1.3 million women are victims of physical assault by their partners. Again, a really big number. 85% of domestic violence victims are women and 15% are men. And, just showing that there are men that are affected by this as well. And, the statistic for men could be low because men aren't reporting. For various reasons, men are not reporting. And so we do find that a lot of the times our statistics are low for men. In most cases of domestic violence, they are never reported to the police. As I was saying before, not only with men, and for different reasons, our survivors are not reporting to the police. And that's an important thing for us as people who are trying to help these survivors understand and accept and kind of work with them on, because we tend to think that that's the best option when it may not be, and it could actually be detrimental to do so. And the last one is, it is estimated that somewhere between 30 to 60% of abusers also abuse children in the household. And for those of you that are working with families, I'm sure that you see this, and this adds a whole layer to really working with our survivors, especially when it involves CPS. So these are just some statistics. They're not the only ones out there, but again, these are the ones that we find to be the most inclusive.
And I just wanted to add, so even though the rates for men reporting is 15% and they could be higher, it doesn't, and I know Ariel didn't mean this, but it doesn't negate the fact that 85% of the victims are female. And so when considering the population, the number that we are working with are predominantly female, is considering what societal barriers that females face in how treatment is targeted and kind of, what's the word I'm looking for? Like, just specialized for that individual person in considering the societal barriers that women face.
So now we're going to just go into a definition of trauma, because our survivors that we're working with definitely face trauma. And I like to use this quote from Bessel van der Kolk. He is one of the leaders in trauma studies and trauma work. This is from his book, The Body Keeps the Score. I definitely would suggest picking up the book and reading it if you want to. It has a lot of great information. But this definition says, we have learned that trauma is not just an event that took place sometime in the past. It is also the imprint left by that experience on the mind, brain, and body. This imprint has ongoing consequences for how human organisms managed to survive in the past. Trauma results in the present. Trauma results in a fundamental reorganization of the way mind and brain manage perceptions. It changes not only how we think and what we think, but our very capacity to think. Again, I choose this quote because it really touches on what trauma does to the brain. And if we really look at it, we understand that this is not just something that happened in the past that we can leave in the past. It really affects us in the future as well. And then just to continue on to the next slide, other things for us to know about trauma. It occurs after real or perceived threat of violence and danger. So it doesn't necessarily have to be after something happened physically. It could be the threat of something physically happening, and we do see that with survivors as well. And the really main core understanding of who gets PTSD or why PTSD happens is the lack of control that somebody feels. It is one of the main predictors of who gets PTSD is the lack of control that somebody feels. So that's just another important thing. And especially when we're talking about domestic violence and IPV, that's all about the person not having control. And then I have one quote from Judith Herman from her book, Trauma and Recovery, which is another great book if you would like to read it. And it's traumatic events are extraordinary, not because they occur rarely, but rather because they overwhelm the ordinary human adaptations to life. Unlike commonplace misfortunes, traumatic events generally involve threats to life or bodily integrity, or a close personal encounter with violence and death. They confront human beings with extremities of helplessness and terror and evoke a response of a catastrophe. Again, just a little bit more understanding of what a traumatic event is and how it affects somebody. And then we're going to briefly go into the neurobiology of trauma. We could spend hours talking about it, but just for sake of time and the sake of this is only 1 hour, I'm going to go by pretty quickly, but I do want to point out three separate things, and that is the fight, flight, and freeze response. Those are the ones that we most commonly are aware of, trauma responses, and those are the ones that we talk about the most. and just to understand what happens when somebody goes through something traumatic or when they feel like they're in danger and their response to that, and really talking to the survivor about these responses. But then there's two other things that I want to discuss in terms of neurobiology and trauma. And the first one is the attachment circuitry that we have in our brain, because everyone has it. Everyone has this this attachment circuitry that keeps us connected emotionally to others. And it's sparked by different things. It could be sparked by someone saying something nice to us. It could be sparked by someone doing something nice to us, or someone needing help and us offering help and reconciling, and all these different things that spark this attachment circuitry with our brain. And what's important to understand is that perpetrators use it to their advantage. They are very, very, very good at manipulating this attachment circuitry. So they know what to say, they know what to do, they know how to act in order to get the survivor to be emotionally bonded to them, right? We see that all the time. That's part of the power and control that they have. What's important to understand is that this attachment circuitry, when it goes on and it's fired, our fear circuitry and our defenses goes down. So when we feel comfortable and loved and attached to somebody, we're not necessarily looking for something bad to happen. We're not necessarily having our defenses on. And so it really leaves us open to getting harmed. And so that's why if we're talking to a survivor and they're saying, you know, but he loved me and I don't understand, maybe I'm stupid, I don't know how I let him do this, I'm really so much smarter than this, we can explain to them, well, has nothing to do with smarts. It has to do with the fact that this person really has a good understanding of attachment and attaching to you, and that they used your attachment and your desire to be bonded to you as a way to harm you. And then the last thing I want to talk about in regards to neurobiology and trauma is the fear circuitry, and how our body remembers and our brain remembers something alarming that happens to us, and it remembers what happens to protect us. So it has a built-in alert system that detects danger and allows us to predict what's going to happen. So, for instance, if an abuser, every time before he hits our survivor says, like, well, you're going to get it. He only has to do that once. For the next time he says, oh, you're going to get it, for that survivor's fear circuitry to come back on and say, oh, my gosh, he's going to hit me. I need to protect myself. And this is really important for the survivor to understand, too, that our bodies are going to react. And that's why sometimes they react to things that aren't dangerous, or sometimes they react and the abuser doesn't do anything, and they're left being like, why am I doing this? It's because of this natural fear circuitry that we have in our brains. So those are just two important things for us to understand, but also that would be really helpful when we do psychoeducation, when it's appropriate to explain to our survivors. This last thing is the window of tolerance. I'm not sure who is aware of this, and you can really get different versions of the window of tolerance if you just Google it. But it really talks about how there's a window of what we can, of our functioning. And when we're in that window of tolerance, we're cool, we're calm, we're collected, we can understand things. That's when psychoeducation is really important, because our prefrontal cortex is working. But what happens is that when a threat is perceived, you could go either way. Our survivors can go either way. They can go above their window of tolerance, so that's hyperarousal. And that's when you see the panic. That's when you see the impulsivity, the outbursts. We see that a lot when they're triggered, and that's when we see the addictions happening. That's when we see them, our survivors, really relying on substances in order to make them feel like they are within their window of tolerance. And then we have and that's where we see the fight and flight responses. That's where we see that trauma response coming on. And then there's the below the window of tolerance, which is the hypo-aroused, which is where we would more commonly refer to as the freeze response. And that is when someone's dissociated, when they're separated from their feelings and their emotions and their self, when they're kind of on autopilot. And why I bring this up is because when we have a survivor come into our office, they can be anywhere within this scale, and it's important for us to realize where they are, because if they're, disconnected and they're not showing emotion, it doesn't mean that they don't care. They could be hypo-aroused, and they may need help getting within their window of tolerance. And the same thing if we see someone with, erratic behavior or outbursts, or we see someone that comes in that's highly addicted to something, we can recognize that they may be hyper-aroused. They may be trying to get in with that window of tolerance, trying to just survive. And then another reason why it's important to bring this up is that our goal before we do anything is to get them in that window of tolerance, and that's where stabilization is really important. And again, teaching them this and having them understand and accept their behaviors like, oh, look, it looks like you may be above your window of tolerance. And so the way that we can do this is we can do this by mindfulness. We can do this by self-soothing techniques. By grounding activities, and if you don't know of any, you can look them up online. I'd be happy to provide you with some, but these are great ways to help our survivors stay within the window of tolerance.
So the big question is, by definition, what is trauma-informed care? Over the years, this has become a big buzzword, but I prefer the definition from the Trauma-Informed Care Project, which they have a website online. So by definition, they say that it's an organizational structure, which I think is important, the word structure, and treatment framework that involves understanding, recognizing, and responding to the effects of all types of trauma. Trauma-informed care also emphasizes on physical, psychological, and emotional safety for both the consumers, or patients and clients, and providers, and helps survivors rebuild a sense of control and empowerment.
And so Howard Bass came up with this understanding of the 3 pillars of trauma-informed care, just for us to keep in our awareness. And they are safety, connections, and managing emotion. So we want the survivor to feel safe. We need to provide a safe environment for them. And part of having a safe environment is being honest, having an honest communication with them, reliability, doing those grounding techniques, keeping them within the window of tolerance, creating a safe environment is really important. And then connections, staying connected to the client. So you want to foster a relationship. You want to kind of meet the client where they're at. We see sometimes the canceling of appointments, and we have to understand where that's coming from, and that may not be because of resistance. It may be because of what they can handle. And then also managing emotions and giving them the power and control. So this is not us telling them what to do. Oh, you should leave them. Oh, you should do this, or you should do that. It's giving them the power and control to do what they feel is best, and to really support and do that, and provide that self-confidence and help them get back to feeling like they have control over their lives.
So the next step is being informed. How do we become informed, and what does it look like when working with survivors? So when considering trauma-informed care and everything that Ariel just spoke about in regards to the window of tolerance, is considering and recognizing that the patient that's coming into your office may have faced or is currently facing more than one form of trauma, and how having multiple forms of trauma over the lifespan, all of that influences the way they respond to you, the way they respond to treatment, and the way they respond to any other person that they interact with in their life. And acknowledging that survivors can be re-traumatized by well-intentioned people. Everyone that's working with this population is well-intentioned. Friends, family, and community providers, including you and me and Ariel, can, for some reason re-traumatize a patient by, somehow triggering something. And that's when, self-awareness will come in, and we'll talk about that in a little bit, but also talking to the survivor about it, which kind of works through the triggers. And knowing that trauma responses are not always friendly. This is a big one, and I think this is really important with people that are working also with people that have addictions and living in shelter, where the trauma responses are not always going to be polite, so to speak. You know, it may be this patient is yelling at you in a tone that you're like, whoa, I've never had a patient speak to me like this, but it's their way of, it maybe have been the only way that with their survivor they could have been heard. And so it just becomes ingrained, their form of communication. It's not to say that they don't like you or they don't think, you know, that you're helping them. And so just for providers, for us to keep ourselves in check in regards to what are our personal reactions to the patients that aren't as polite to us, or in our view, what we view as polite. Emphasizing physical, psychological, and emotional safety for both the patient and the provider. For the clients or patients that you're seeing, like, you know, I always think of Maslow's hierarchy of needs. Like, if their physical needs are not being met, like, how can we, you know, move on to the psychological aspect of it and the emotional safety? Like, yes, we want to try to target all of them, but always beginning with the basic needs for life in order to be able to get them into the window of tolerance and dealing with the emotional and psychological pieces of it. And being informed in regards to knowing where they end and you begin. So what are both of you bringing to the table? And we'll talk about this a little bit in a little bit about how, you know, things from our personal lives may influence how we're interacting. Because, again, this is 1 in 4 women. You know, I'm sure that there are people on this webinar right now that have personally experienced either someone in their life or themselves going through a situation of domestic violence, and it's very easy to, you know, for that to become triggered when working with this population. Something else of being informed is being mindful when interacting with these patients. Of they oftentimes come in with a lot of misdiagnoses from psychiatrists or other mental health care providers, and they've been labeled multiple times, especially if they grew up in the system. And so one thing that we often see is patients will come in with like bipolar, borderline. They have all of these labels for themselves when a lot of the times it's simply trauma responses. But, you know, in order to get some sort of medication or some sort of treatment, they've been labeled as something by providers that are not necessarily trauma-informed. So being mindful of that when suggesting medication or suggesting seeing a psychiatrist. And also understanding signs of self-medication. You know, a lot of patients would rather smoke weed at night versus taking a sleeping pill. Like, just recognizing where that patient is at in regards to treatment and what they're doing to self-medicate, to cope basically with the trauma that they've gone through and what they want to do with it. Because again, it's not about us, it's about them, but of course, you know, it's our hope that they would be on a healthy path in regards to maintaining and self-regulating. So self-awareness and countertransference. This is aimed at us, the providers. So these are some tips that we collected from our patients, of things that they've heard from mental health care providers or some sort of person in a helping role in their lives. So how can you love him? Like, these things seem really far-fetched, but they're more common than not that we hear these things from people that we work with. Abuse tends to be common in your culture. It seems just unbelievable, but it happens. Why don't you leave him? Insert clinician inappropriate self-disclosure. This is where it comes in. You know, we've had people who, past clinicians have said, like, you know, I've experienced domestic violence in the past, and I know you can get through it because X, Y, and Z. It's really self-monitoring whether or not is that for you or is it for the patient. And is it going to be detrimental to the treatment? Just call the police. That's a huge one. Where it's like the police are not always the answer for survivors of IPV, especially depending on the communities that they're coming from. The police may seem like a safe option for you or for me, but it may not be for that client, especially if they've had negative experiences with the police in the past, or their survivor that has police with it, you know, either their abuser or their abuser's family. Like, we just don't know. So don't assume that calling the police is the right answer. Same thing with you need to get a restraining order. Sometimes getting a restraining order can be super helpful, and well-intentioned people think that, you know, that's going to help. But that often comes from provider anxiety. So for the provider, it's trusting the survivor to know whether or not the restraining order is going to stir the pot, like poking a sleeping bear with a stick, or it's, you know, he seems like a law-abiding citizen, whatever that means. But, like, you know, is he someone, I always ask the patient, does he seem like someone that cares about the law? And they usually can tell you right away, no, he does not care. You know, that's a good way to gauge whether or not it seems like it's a safe option or not. Because at the end of the day, a restraining order is a piece of paper, and they don't work unless they're enforced. So always checking in with the patient.
And just to add about those last 2 points, too, it's also about giving the patient power and control back. So we may say this is the best option, we may think it's the best option, and in some cases it may be, but we again have to make sure that we are having the client to have the power and control in the situation.
Mm-hmm. Oh, and the last one that I had just put up, why are you screaming at me? That goes back to the, you know, forms of communication that has been normal for the patient, that, you know, either that's the way that they've communicated with their abuser, whether or not that's, you know, different cultures speak at different tones and different levels of volume. Like, all these things need to be considered when, before we get offended as providers. Resulting in provider anxiety, victim-blaming statements, personal experiences with IPV, how that influences things in the way you respond. And I talked about most of these, I think, in the examples. But, the savior complex as well. In, like, it's not our job to save the people that we're working with. It can be extremely anxiety-provoking, but a lot of times as providers, it's easy to go into this mode of needing to save a survivor. But really, like, the best thing that we can do for them is just let them take the lead and then provide them the information that we know in order to help them make the decisions. And as providers, being okay, especially if you're therapists, being okay with referring out to specialized programs that work specifically with this population. It doesn't mean that you're failing. It's just doing what's best for the patient. And also, you know, going back to the just call the police statement, it's how you individually handle trauma or violence, and considering, okay, is this my response to trauma and violence, or is this theirs?
And also understanding the trauma responses, and going back to what, you know, the screaming aspect is, you know, are they screaming also because they're above their window of tolerance? Do they need to be brought back down? Do they, you know, are they feeling safe right now?
So implementation of TIC and what it looks like. This is the doing part. So safety planning, physical and emotional. Considering, you know, Maslow's hierarchy of needs, as I also often consult, but really also focusing on the emotional piece of, like, what are things that they can do when they become triggered? How, you know, this is where the grounding exercises come in, and also safe people in their lives that they can contact if they become triggered, or people that they can spend time with that are safe people, you know, to get their mind off of their fear reactions oftentimes, and just the different ways that people in their life can support them while, you know, if they're either trying to leave their abuser or currently going through the cycle. Personal advocacy, it's pretty self-explanatory, but it means the world to patients, especially when they're in a system that is often victim-blaming. Healthy boundaries for both the provider and the client in regards to, you're not on 24/7 with these patients. It's easy to go into that mindset, but you know, just recognizing what you had to do to take care of yourself so that, you know, the next day you have something to give. Appointment flexibility is huge because most of the time these patients have 1,000,001 appointments going on, especially if they're needing, you know, to get benefits, if they've left the home, if they, you know, have children that are switching schools, all of these things, and also just keeping track of the appointments when they're in crisis mode is really challenging. As a provider, having patients with emotional responses, community supports, getting them connected. A lot of these survivors have been isolated, so, you know, part of giving the care of TIC is like making sure when you're not available that they have a support system around them to ensure safety. No victim blaming, psychoeducation about trauma responses. I think Ariel covered that. Considering the role of culture, community, and spirituality. A lot of patients rely on their faith and their culture when they're going through situations of domestic violence, intimate partner violence, and how that community influences the way they handle the situation and the way they respond to you. Because I think most of you have probably experienced clients being distrustful of new people because they've just either been taught by their abuser not to trust anyone, or, you know, they were told, you know, not to reach out and get help because it needs to stay within the community. These are all things just to consider when working with this population. And environment, pretty self-explanatory, but just that also includes how welcome they feel when they come into the office or the space where you work, from the first person that they make contact with to the waiting room area, because this is a population that basically their self-worth has been, you know, taken down to the lowest level by their abuser, and oftentimes, like, we have to work with them a lot on self-esteem, as I'm sure most of you know, and so, you know, making them feel like they're worthy of being in the space where they're coming to see you.
So we're going to go briefly, because we are running out of time, over the do's and don'ts of trauma-informed care, and Kylie really explained a lot of the do's, so I'm going to go pretty quickly. We want to validate their emotions. We want to not ever say that their emotions aren't real or it's just a phase. We want to make sure that they feel comfortable expressing their emotions. We want to be patient. This is hard to do, especially for those that can only see patients for a short amount of time or can only see patients for 10 sessions and then have to refer out, but we have to be patient. This is a process, and this is something that's been ingrained in our survivors for a while, so we have to be patient, especially when Kylie said about canceling sessions and rescheduling sessions. We have to be understanding of that. Recognize our own transference and and consider counter-transference. Kylie did a great job of explaining that as well. We want to meet the client where they're at, and in parentheses we put right side to right side communication, really talking about the right side of the brain. If we're having a client who's really having an emotional reaction to something, or is really just working with maybe without their window of tolerance, we don't want to respond back with facts. We don't want to respond back psychoeducation. We really want to meet them where they're at. So if right now they're having an emotional reaction, we want to meet them with a consolation. We want to talk to them. We want to help them, feel supported. We don't want to go into doing the heavy lifting right now. We want to really just meet them where they're at. Be aware of trauma symptoms, which is what we talked about, and then using the grounding exercises to really help them build their window of tolerance. And then when we go over to don'ts, again, a lot of this is review. We don't want to question the survivor in front of the abuser. This happens, we've seen it happen within our hospital setting. We've seen this happen in other settings as well. And we really want to be mindful to not do this, to not put a survivor on the spot to talk about something that happened to her with someone who is dangerous to her, and we want to make sure that they have the privacy and confidentiality that they need. We don't want to recommend couples therapy. It is proven that couples therapy does not work with abusers and perpetrators of violence. They are manipulative in nature, and doing couples therapy will only highlight that. We don't want to categorize victims into good or bad victim, and Kylie really did also explain that as well. Of we you know, although we have a favorable we have favorable interactions, we want somebody who's going to listen to us and talk to us and not, you know, show all those uncomfortable reactions that Kylie was talking about before. We also have to understand that where those reactions are coming from, where the behavior is coming from, and understand that this is trauma that we're dealing with and people who've been through a lot. We want to provide psychoeducation when the client is, we don't want to provide, psychoeducation when the client is activated or not within the window of tolerance, which goes back to the meeting the client when they're at, because you can't really do anything when a client is just purely reacting, because the prefrontal cortex is not even online. So we really want to do it when it's appropriate. It could be really effective, but obviously not all the time is it effective. We don't want to give ultimatums. We don't want to say, well, I'm not going to see you unless you leave him, or you can't do this until you leave him. I'm not going to do housing if you leave him, because that's taking away all the power of our clients. You don't want to force medication. You know, as Kylie had spoken about before, some of our clients are misdiagnosed. Some of our clients don't want to take the medication that they're given because they feel like it's not helpful, and we don't want to it goes with giving ultimatums. We don't want to give an ultimatum, well, we're not going to see you if you don't do this. And then you don't want to assume that calling the police is safest. And again, Kylie really explained why that may be very well. Do you want to add anything, Kylie?
I just wanted to go back to the couples therapy piece, because this is something that we frequently see with our patients. Either they've experienced it or they've at least had a therapist encourage it. And this is something that has been really damaging to our patients, because what ends up happening, the only time I've seen it be successful is when a patient is in therapy for themselves and also their abuser is in long-term therapy for their own issues, and they're able to admit that they have a problem. And then at some point, they come together and have couples therapy. That is the very, very 2% rare occurrence that the abuser is actually able to admit that they have a problem. So when you recommend couples therapy to a patient, a survivor, it's basically like setting the survivor up to being vulnerable in a setting that their abuser can later go home and use that information, that vulnerable information that survivor provided in session, against their survivor. So this is something to keep in mind when if the abuser is not able to admit that they have a problem and actually believe it, couples therapy is only going to be damaging to the survivor. Good. Thank you. So review. We have almost 10 minutes left. So just quickly, going over just in a nutshell the things that we've talked about, and then we'll do some question and answer. So if you can take away 4 things from today, it would just be that domestic violence is about power and control. That is the main goal of the abuser, and keeping that in mind when tailoring treatment for your survivor. 2, trauma responses look different in each survivor. I think we pretty much covered that in regards to, you know, one patient may be crying and talking in a soft voice, and the next patient that comes in may be screaming at you, and they both are equally traumatized and survivors. Clinician self-awareness is crucial while working with this population. And 4, the 3 pillars of trauma-informed care are safety, connections, and managing emotions. So we included information about our program. Ariel, you want to go over this?
Yeah, I'll go over it really quickly. So we're located at the New York Presbyterian Hospital up in Washington Heights. We don't have a catchment area, so if you want to refer somebody who, is from the Lower East Side, or we even see out of state, if they can get here and they want our services, we can serve them. We serve 12 and up. It's anyone who's experienced any kind of violent crime, so domestic violence, physical or sexual assault, or elder abuse. It doesn't have to be something that just happened. It could be something that happened in the past. And we provide crisis counseling, trauma therapy, accompaniment during state exams, training and education, information and referrals, as well as coordinated services. And the line that we have there, the hotline, it's a message system, so whoever wants, the survivor can call, or a clinician can call and just leave a message with information, and somebody who's on call during the week will give you a call back.
So just so people know that it's not, the hotline is kind of misleading because it's a recording system. So there is someone on call every single day of the week at Dove, the work week. On the weekends we have advocates if someone comes into the emergency room. But Monday through Friday we have an on-call clinician each day, but you do have to leave a message on that line because no one will ever pick it up. It's just leave a message and it's returned.
Yeah.
And community resources, just added some local, like state, national, and then within New York City, different community resources that we thought would be helpful when looking for services or information for yourself or for clients. And then our contact information here at Dove.
So you can contact us if you have any questions about this or referrals or anything of the sort.
Giselle, if you want to open question and answer, I think we're at that point.
Okay, so thanks, Kylie and Ariel. So we have, so I just want to remind everyone, we have about 8 minutes or so. So if you do have questions, please go ahead and enter them in the chat box. But we have a question about, so what your thoughts are on about questioning the abuser in front of the survivor. No.
So what is the question exactly?
So someone wrote in just your thoughts on having to question the abuser in front of the survivor. That's
what you got? Okay. So basically, this is a scenario that I witnessed once. NYP wouldn't really like me saying this, but here at NYP, in the emergency room, I had a client. I was on call to the emergency room. The woman at the front desk of the emergency room, my client came in with her abuser. He brought her to the emergency room and said she fell, something happened to her. The woman at the front desk literally asked her, is this domestic violence related? Like, for us, that's like, what? How can that even happen? But people in the community that are not working in this field become like deer in headlights when they think that DV is occurring. So when we say not questioning the survivor in front of the abuser, it's more so like if you suspect that there is domestic violence, just trust in your gut that that survivor, if you ask things in front of that abuser, she will be paying for it when she goes home later that day, most likely.
And I believe the question was questioning the abuser in front of the survivor. Is that the question?
Yes.
Okay.
Oh, sorry.
I'll just give, I think best practice is really just not questioning in front of one another. That's what I would use as best practice. Because for various reasons, I think that it could be re-traumatizing for the client. I think that we also have to, the survivor, we also have to realize the manipulation that very openly, I would very highly doubt that a abuser would say, yep, I punched her and kicked her and I abused her. That wouldn't happen. And if it does happen, that's a very rare scenario. So I don't see the purpose of questioning the perpetrator in front of the survivor. If possible, in my opinion, best practice is to do it separately if you have to talk to the abuser as well.
So I know we need to move on to this question, but I say, like, what I said I think is still applicable if you just flip it around, because if you're asking an abuser in front of the survivor, the focus is still going to be on her in a way, and when she gets home, she's going to be the one that, you know, suffers the consequences of most likely narcissistic person being accused of abusing someone. So it's considering, you know, who are they going to take that out on at the end of the day? And we know that answer.
Okay. So I'm going to try to get in a few more questions in the 5 minutes we have left. Somebody asked, you know, you stated your program serves clients from age 12 and above. And so how do you involve parents or legal guardians in your work, bearing in mind the trauma-informed care model?
So Ariel and I are two of the people here that work a lot with the younger population. And the way, at least I see it, is you can't work with the child unless you work with the parent. And so, you know, usually it really depends on the situation, but I try to constantly be in contact with the guardian or the parents of the child that I'm seeing. Now, we don't work with the abusive parent if there's an abusive parent involved, but the non-offending parent, we definitely bring into session, or at least I do. I try to see them in a joint session at least once a month with the child that I'm seeing, because again, you really, if the child is going home to that environment, like, you can't treat the patient and not treat, you know, the person that's raising them as part of treatment as well.
I agree with Kylie. I would say that, you know, the caveat for me would be if my child patient does not feel comfortable having the parent in the room, then that's okay. And we also work where one of us would see the child and one of us would see the parent in order to make the child feel like this is their own space. And so also the parent can get support as well.
Okay. So someone also asked, again, quickly, if you have a resource to share for grounding exercises. Yeah, I can, if they want, they can email one of us personally. You could really look it up. There's there's a ton of different ones. There's the 5 elements. There's a bunch of things that they email us. We can definitely provide resources. Okay, and then I'm going to give just one last question, which is how, as a clinician, can we avoid misdiagnosis for clients who particularly would benefit from a trauma-informed care approach? How to avoid misdiagnosis, I guess, is what really they're asking.
I think really, in my opinion, is getting a good understanding of what PTSD is. I think what happens is that a lot of people don't look to PTSD, look for more diagnoses that are more easily treatable. So I would say understand what the trauma responses are, understand what PTSD is, you know, listen to the survivor, really listen to what's going on in their life.
I also think that it's going back to the informed piece of doing trauma work. So, you know, is it taking workshops? Is it becoming more familiar with the different trauma responses? Because I think once you start to look through a trauma lens and recognizing what are natural trauma responses, it's going to shift the way you look at the patient that you're diagnosing. It just becomes automatic. Like, once you inform yourself, it's like you can't take that education away.
Okay, great. So I think we're going to just wrap this up because we have one additional, less than a minute left. So I want to thank Kylie and Ariel and thank everyone for attending today's webinar. So if you have any questions, you can contact us at CTAC, which is, our email is ctac.info@nyu.edu. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that. You can also you will be able to find the slides on our website. That was posted earlier. I'm just trying to give you the right information. Bear with me one moment. So, yes, you will be able to find it at our website on CTAC. And on the slides, you will also be able to find Kylie and Ariel's contact information. So thank you again, and on behalf of CTAC and Kylie and Ariel, thanks for joining us. Have a good day.